Hello, my name is Kate Nightingale. I am CNC Palliative and End of Life Care for Far West Local Health District, and I've been asked today to talk to you a little bit about communication at end of life, or more specifically, communication in the very last days and hours of life. So I've got this little quote from George Bernard Shaw that says, "The single biggest problem in communication is the illusion that it has taken place." And I guess the reason why I put it in there is because it really is, end of life for families is a very, very stressful time. It can be very emotional, and that sometimes we think as clinicians that we've communicated well with the family, but their experience or their perception is that they haven't really understood the process. So I put that quote in there just to remind us that we need to really be very clear and be a little bit insightful into our own communication styles and making sure that our message has really gotten across. So why is communication in the very last days of life so important? For obvious reasons, and I'm sure that you've previously done quite a bit of work around communication in general. You're in a helping profession, so that's generally something that comes quite naturally to a lot of helpers, is being good communicators. But at the very end of life, it becomes even more important, because for the person who's dying, good communication means understanding. So the ability to be able to talk openly and honestly, and having a trust in your health professional, and having some more peaceful interactions, or interactions that are more meaningful. For families, good communication means that they understand the dying process, and that it recognises that those people are the primary caregivers and know the most about the person who's dying. How we communicate with people impacts on their perception of the care that's delivered, and has subsequent effects for how the person has perceived the care in general, and then ongoing into the bereavement phase. So good communication can actually impact in a positive way on the grieving process. For health professionals, good communication normalises death and dying. It is part of the provision of holistic care. It increases our work satisfaction. And I've got a little quote that you can read on there about the fact that communication is more than just the sharing of information. It's the process in which that occurs. So it's everything. It's our body language, it's our tone, it's our intention, and that all together, that whole process creates a shared meaning. So what types of conversations can occur at the end of life? Talking with patients and caregivers who've just received bad news, talking with families of seriously ill patients, talking about spiritual and religious issues is a difficult conversation that quite often we pay a lot of lip service to, but we don't actually do it very well in a lot of settings. And I say that even as a CNC and someone who's worked in palliative care for about 20 years, I still find it confronting sometimes to be talking about spiritual or religious conversations where I feel a little bit out of my depth. In discussing advanced care planning and NFR orders, talking with patients and families about symptoms, particularly where those symptoms are intractable or we're finding it really hard to get on top of, talking about suffering, and talking about fear. So when do we have end-of-life conversations? We have those conversations when it's clinically recognised that the person's illness is irreversible and actively deteriorating. This, in particular in the residential aged care setting, can mean that the person is quite often known for a long period of time and has had a period of relative stability, and it's the people who are with those residents all the time who start to notice that the person has started to deteriorate. That's when we have the initial conversations about, well, you know, if you continue to deteriorate, what is it that you would like for your care? And that's where advanced care planning and advanced care directives come into play. But then when we see that that dying process has really started, it's really important that we have conversations with people, with families, that they understand that this is a deteriorating phase and the person is unlikely to recover. Sometimes those people could have had several episodes of deteriorating. For instance, in the context of people with chronic diseases, they often have a trajectory that's a bit like a roller coaster. So they could have had 3 admissions in the past 12 months to hospital, where it's possible they could have died that admission, but they actually recovered and went back to their residential aged care facility. So it's important to remember that sometimes those families have been through that roller coaster. It's really important to see the patient in the context of their illness. When a really important one is when patients and families request to have the conversation. So sometimes it can be a case of a patient or a family member triggers a conversation, but we don't necessarily recognise it. There is an example I've had recently of a resident in an aged care facility who said to one of the staff members, "Oh, when I die at my funeral, I would like XYZ played." And the staff member, her initial reaction was one of discomfort, and she wasn't comfortable talking about that, so she shut the conversation down and distracted the resident to something else. And when we had a chat about that, she realised that that was actually the person giving permission to open a conversation about what that person actually wants for their end-of-life care. So recognising triggers for conversations and recognising when people are giving you an open invitation to talk is really important. When there is a clinical episode that requires a revision of treatment goals, so somebody could have a particular treatment plan, they might be having some long-term oral chemotherapy to manage a malignancy, and at some point they have an episode of deterioration and their treatment goals have been revised, and it may be that they're going to go onto a purely comfort care plan. When that happens, it's really important that that's communicated clearly to the patient or the resident and the families, and that may mean, of course, it's the leading medical practitioner whose job it is to have that initial conversation, but it's really important that we have a good understanding of what that conversation has been, so that when families come back and ask us questions, we're giving the correct information. And it's not uncommon for families to ask the same question of several different clinicians, sometimes hoping for a different answer. So being able to collectively, as a team, give the same information to patients is very, very helpful, not only for us as staff members, perhaps getting a little bit confused with the same conversation all the time, but also for families knowing that they're getting the same information deems it must be correct. Making sure that we're aligning care to patients' preferences. So making sure that the care we're providing is actually what the patient wants, never assuming what somebody wants. If they haven't told you what it is that they want for their care, it's really important to ask. And end-of-life care conversations also support a natural dying. So that may be in a residential aged care setting, a person may have documented in their advanced care directive that in the event they have an irreversible condition, they wish to remain in the nursing home and not to go into a tertiary or a hospital setting. And if that's the case, it's really important that we're all having good communication between staff and between families, that this is what the person has said that they wanted, and so that's what we're going to support. So some of the roadblocks to good communication at the end of life, a big one is coming from a place of judgment. So we are all guilty of thinking that we know better than somebody else does, even if that is their own personal preference. And it's really important to have a sense of insight into what your own biases are. So not coming from a place of judgment it's sometimes quite a difficult thing to do, particularly if something doesn't sit well with you. If that's the case, being aware of it, talking with your colleagues, talking with your specialist palliative care clinicians can help you to sort of navigate difficult situations. Another roadblock is suggesting solutions, so trying to fix a problem. It's not uncommon for people in helping professions to want to fix problems. I know I myself am a fixer, and I've got some pretty good insight into that. The problem with fixing it is that it's not our job to fix certain things. It's our job to provide good palliative care, to have good communication, and be able to navigate the system of palliative care and aged care really well. But we cannot change the outcome or the trajectory for that person. If that person is going to die, then that's what's going to happen. And there is often a case of, we can have patients or residents and families that have had really complex psychosocial situations, and there is no way in a few days at the end of life that we as clinicians are going to be able to fix any of that. Avoiding concerns is a big one also. We tend to, as clinicians, when we're uncomfortable in a situation, we will avoid that confrontation or that conversation by actively doing something that we are comfortable with. So an example of that is going into a room where you know that people have lots of questions you don't feel comfortable answering, so you go in and you make it your sole focus to fix the Nicky T driver, or to fiddle around with something to do with that person's care that you are comfortable with. So doing that puts a block and puts a barrier up so that the family don't feel comfortable having that conversation, and gives them the message that you're not comfortable. So making sure that when you go into a room, even if it is to provide care, that at some point you take a step back and you stop doing the task that you were doing and look directly at the person and provide the body language that you're interested in engaging with them. And applying labels to people. So one of the biggest labels that we see in end-of-life care is the label of they're in denial. So somebody will be labelled as being in denial if they haven't understood a process, or they haven't been willing to engage in conversations. It's really important that we meet people where they're at, and that we don't apply that label, because labels are really hard to dispel. So that's some of the roadblocks to good communication. I'm sure that there's others. What does good communication look like? Good communication, we know it when we see it. So it's having a warm connection. It's having the right body language for the situation. It's being receptive and curious. It's having an awareness, like I was talking before, having insight into our own personal characteristics and our own tendencies, and then being able to navigate situations, having an awareness of what you tend to do. And we come from a place of empathy. So I've included a video there of a wonderful woman by the name of Brené Brown, who does a fabulous video. It's like a little cartoon about empathy versus sympathy, and how to recognise empathy and the impact that empathy has. I really recommend that you watch it. It's a great little video, and essentially it is not trying to fix a solution, but trying to be present in that space and allowing the situation to evolve. That empathy is not feeling sorry for somebody, but empathy is saying, I know that this is really hard, I'm here with you. So like I said, essentials for good communication are to understand yourself, to have an appropriate setting. So if you're going to have a really sensitive conversation with somebody, it's a good idea to not have it in the corridor, to have it in somewhere private. You can bet your bottom dollar that as soon as you're having a really sensitive conversation with somebody, that somebody will start up a leaf blower or a lawnmower outside. Some things can't be helped, but we can help the situation by, perhaps telling kitchen staff or cleaning staff, look, I'm going into this room to have this conversation, the door will be closed, please don't interrupt us, we'll come in and let you know when we're finished. Having appropriate timing. So timing is a big one. A lot of people say that they find it difficult to have conversations about advanced care planning or conversations about end of life when they're first, say, admitting somebody to a residential aged care facility for the first time. And that's entirely understandable, because it's a time of huge, flux and change, and it's a lot of information to give somebody at once. They've often come from hospital, or the situation leading up to that, going into care, has been fraught with emotions as well. So that's not the best time to have that conversation if it can be helped. So making sure that we're having those conversations when we need to have them is very important. And another essential is that it doesn't make assumptions. And like I said before, never assume anything about anybody. Always ask, and there are ways that we can ask questions that are not intrusive but are inquiring and curious, that don't get people off on the wrong foot. So most people appreciate being asked. So if I was to walk into a room and be wanting to know what somebody wanted for their end of life care, there are ways to ask that to be able to elicit the information. When we talk about having difficult conversations, a lot of people worry that they don't know what to say and that they might say the wrong thing. So I've put this little thing in the PowerPoint that says body language accounts for 58% of communication. Our tone of voice accounts for 35%, and the words we use are only 7%. So generally speaking, it's not actually what we're saying that is what we're afraid of. We need to know that it's actually our body language and the way we say things. If we can master those, that the rest will follow. So in the last days of life, we always assume that even if somebody hasn't got a level of consciousness, that we always assume that they can hear us. So I quite frequently tell families that hearing is the last sense to go, and to talk to the person as if they were awake. Hallucinations and symbolism is a really important one. So sometimes, or it's quite frequent, that people in the last days of their life will report visual hallucinations. Quite often people who have died, they are seeing family members or friends who have died earlier. And I explain to people that that's actually that's a common occurrence, and as long as the person isn't being distressed by it, that it's not something that we worry about. And in actual fact, it can provide a lot of comfort to people. Spirituality, it's really important, regardless of our own spiritual beliefs, that we actually ask somebody, what this means for them. So making sure that you have taken note of the person's religion, that you've asked them if there's anything that they would like you to do as a staff member to facilitate. So it could be, if the person is Catholic, asking them, do you wish to have a priest visit to do last rites, or to contact another type of pastor. So spirituality is something that we quite often neglect to talk about, because it can sometimes be uncomfortable, but it's very important that we do have those conversations. We get really common questions from families. So common ones are, how long will this last? Can you tell me, is this still going to be going on tomorrow? It's really good to answer questions that you cannot give an answer to. So we can't say how long something is going to be, how long it will take somebody to die. Quite often it's the person's own timeline, and their body is in control, not us. So I usually respond with an I wish statement. So if somebody says, I want this to end, I don't want to see her suffering anymore, you might respond with, I wish that it was easier at the moment, or I wish that I could tell you how long. However, I can't tell you how long. We just have to provide good care and make sure that she's comfortable and allow the natural process to occur. Euthanasia related questions come along quite frequently, and usually people just want to raise the question because it's in our media, particularly since Victoria legalised physician assisted suicide. It's really, really important that we don't block those questions, because they're often gateways to other things. So somebody asking about euthanasia doesn't necessarily mean that they want euthanasia. You need to answer it appropriately. So responding again with, I wish that I could give you the answer that you wanted. However, in this state, in this country, we cannot assist somebody to die, but we can provide good symptom control, is a way of dealing with that question. So the other one is, how will I know when death is near? This is one that you can usually answer. You might say, you will start to notice changes in breathing, changes in skin colour. Sometimes we get a lot of warning and sometimes we don't. It's quite common that people actually want privacy in those last few minutes of life, and it's how often do we hear of families holding vigil beside the bed, and it's only when they leave for 5 minutes to grab a cup of coffee that the person dies. So I often will say to families, I just want you to be aware that if your mother, father, whoever it is, dies when you are not in the room, it is not a source of guilt. It is when the person has chosen to die, and that often people need privacy. Communicating changes about like when somebody's dying, using the ask, tell, ask method is a really good way of making sure that the person is understood. So when we're in an emotional state, like you would expect if somebody is dying, we only really take in about 30% of what's being said to us. So it's quite common for somebody to ask the same questions over and over again. So it might be that the person says, how can I tell if death is near? And you say, this is what you might start to see. You might start to see skin changes. You might start to see changes in breathing. What other things have you noticed? And so asking them to, make an observation will give you an indication of what their level of understanding is. And making sure that if you have a resident who is in the obvious stages of dying, that when the family go to leave for the night, for instance, that you make sure it's documented really, really well who the person is to contact if the person dies in the middle of the night when nobody's there. So, and making sure that it's really clearly articulated. Things to avoid in communicating with patients and families at the end of life. Discussing your own thoughts and beliefs is not appropriate. Shifting the discussion to focus on your feelings, again, not appropriate. And this is stuff that we know as clinicians. And offering platitudes is a really big one. So sometimes when we're uncomfortable, we use euphemisms, saying to somebody, but they had a good life, is not a really helpful thing to say. That's being disingenuous. So people pick up on these things. They know when you're being genuine. Saying things rather than saying, they've had a good life, you might say, I've really enjoyed looking after your mother, your father, and being able to share some story about the impact that they've had on you while you've been at work. That's a more genuine way of communicating with someone than giving some corny phrase to them. And using euphemisms, so we need to clearly use the right language around death and dying, like using the terms death and dying, or they are dying, rather than using euphemisms which can be misconstrued and are often something that we do in our culture when we're uncomfortable. So using phrases like they've passed away or they've gone to God are euphemisms. We really should get comfortable with using the words death and dying, because in us being comfortable, we're giving other people permission to use the right terms. So in terms of the residential aged care setting, we always need to remember that person who's dying is part of a larger community. They may have been in that facility for some time, and that is really their family. We need to appropriately and sensitively communicate the person's deterioration or their death with other staff and residents. And that we need to foster this open and honest communication. You know, people are not silly. They know, you know, if the person who sits at their table is there every day for 15 months and then one day they're not there and nobody is talking about it. You know, we should be able to say, you know, with residents and with other staff, you know, that person is deteriorating. It's looking like they're dying. Is there anything that, you know, you would like us to do or say? You know, being able to support the other people who know the resident is very important. And some facilities have particular ways that they honour the deceased and dying. So some facilities have a remembrance book. Some facilities have a minute's silence after a mealtime. Some places have a guard of honour. So being aware of what your particular facility does to honour the deceased residents is a really good idea. I've put this in here. In times of when you are in the presence of distress, go silent. If you don't know what to say, it's okay to say nothing and sit in silence. And silence is actually a really good way of allowing the conversation to naturally either continue or come to an end. And it also tells the person that you're sitting with that you have the time to sit there. So silence is, you know, it offers lots of different mechanisms for communication. It's something that I struggled with quite a lot, and it took quite a bit of practice. Managing difficult emotions is a learned skill. So being in a situation where you are struggling, which can happen with residents that you know really well or that you've got a particularly close relationship with, that, you know, it's really important that you check in with yourself and that you are aware of your own boundaries. And when you are struggling, being able to say, I'm really struggling with this, is, you know, a good way to go. You can practice the interaction ahead of time. So you can imagine what responses you might have and then practice how you might respond to that. It might be something that you practice with your team members. Recognize when your emotions are impacting on your thinking. It's okay to get a little bit teary. If you're talking to a family about a resident that you've looked after for a really long time and you're upset that their life is coming to an end, that's okay. There's a difference between showing emotion and showing vulnerability and sobbing like a baby in the corner, which I don't recommend. So giving yourself time to allow that emotional intensity to subside is also one way of utilising silence. If you're feeling overwhelmed, it's perfectly fine to excuse yourself and say, look, do you mind if I come back in 5 minutes? I'm just really struggling at the moment and I want to be really clear about what we're talking about, so I'm going to step out and come back. Is there anything I can get for you before I leave? And then you can come back and resume the interaction when you've composed yourself. Validating the person's experience. So if you're sitting with somebody who is perhaps showing signs of frustration or anger, you can actually name it and say, you seem really frustrated. And sometimes validating that person's emotion brings the tone right down as well. thank you very much for listening. Sorry if I've waffled a little bit. I've included some references here, and I highly suggest if there's any training available in your area to do with communication or having difficult conversations, that you get along to the training, because it's something that is part of lifelong learning, and sometimes we do it well and sometimes we don't, and that's okay too. I've got 20 years experience working in palliative care, and sometimes I don't say the right thing, but it's about recognising when you haven't done such a good job and then working out what you're going to do about it. So thank you once again. Take care.